From the JAMA Network, this is JAMA Ophthalmology Author Interviews. Conversations with authors exploring the latest clinical research, reviews, and opinions featured in JAMA Ophthalmology.
Hello and welcome to this author interview from the JAMA Network. I'm Neil Bressler, Editor-in-Chief of JAMA Ophthalmology, and today we're going to look at low dose, specifically 0.01% atropine eye drops for slowing myopia in children. And joining me is the chair of the study that was evaluating this with PDIC in a randomized clinical trial, Dr. Michael Repka. Dr. Michael Repka is professor of ophthalmology at the Johns Hopkins University School of Medicine and a past chair of PDIC. Michael, thank you for joining us.
Neil, it's my pleasure to be here to talk about this research.
Maybe we could just start with why atropine drops to try to control myopia? What's the biologic rationale behind all of that?
Neil, I wish we knew why atropine would have a benefit. It's been known for at least 50 years that high-dose atropine, the 1% formulation, seemed to slow progression of myopia, but it had so many side effects, which I think we all are well aware of, constant dilation, inability to see it near, light sensitivity, just wasn't going to be a useful treatment. But then some researchers in East Asia, specifically Don Tan and his group in Singapore, used 0.01% as the control arm of a study and found that it seemed to work, and that this treatment now has taken off. Lots of research worldwide on what strength, what formulation of low-dose atropine can work to slow progression of myopia.
All right, well, let's get into your study. So this was a randomized clinical trial, and it was among children, as I understand, that were from 5 to 12 years old, and approximately half of them were assigned to get these atropine eye drops at 0.01%. And then the control group, did they get placebo drops?
They did get placebo drops. It's important, though, to note that our study had a 2-to-1 randomization. 2 patients got atropine drops for every one that got placebo drops.
And they were followed out for 2 years to see if this atropine drop might slow down myopia progression. So how did you determine myopia progression? What was the primary outcome, and how did the group determine this?
So the primary outcome measure for this study, we elected to choose cycloplegic autorefraction data and looked at the change in cycloplegic autorefraction over the 2 years in both the atropine eyes and in the placebo eyes. We included both eyes and did appropriate adjustments for that.
And about how many children ended up participating in this?
We recruited 187 children into the study. And as I mentioned, the randomization was 2-to-1. So that in the treatment arm, there were 125 patients, and in the placebo arm, 62 patients. And again, that was by design.
And how often were they taking these drops?
These low-dose atropine drops are being used today every night. So they were advised to take nightly, and they were really, really good about compliance.
So I understand you had excellent follow-up. About 95% of these participants came back through the follow-up of 24 months. But how good was the compliance? How do you measure that to determine, are they getting the drops in? Are the parents or caregivers getting the drops in? How do you actually measure compliance?
Compliance with eye drop therapy in these myopia studies has been very difficult. We don't have a dose monitor that could watch the drop be put in. So we did rely upon 2 tools. One, we didn't enroll patients who would not take artificial tears before the study as sort of a run-in phase. And then we did reminders to the families. We had calendars, and we did ampule counts of how many were returned.
Okay, that's probably as good as we're going to get to know, and hopefully with the randomization, the compliance, whatever it may be, is similar among the 2 groups. So let's start with the placebo group. What did we learn about myopia progression in your placebo group at 24 months? How much myopia progression was there?
The placebo group progressed by zero point 0.8 diopters of increased myopia over 2 years, or about zero point 0.4 diopters per year.
About 0.8 over 2 years. So what happened with the atropine group? How much did they progress?
So the atropine group progressed 0.82 diopters over 2 years, or essentially the same amount of progression.
So you really didn't see any difference there when you used 0.01% each evening in terms of myopia progression out to 2 years. Is that correct?
That is correct. This treatment did not, in our sample, affect myopic progression.
Now, how does that compare with the literature then? Because recently there have been several clinical trials that at least the headlines suggested that they actually could use 0.01% atropine and slow down myopia progression. Is that true, or are there limitations to these other trials?
Well, there are studies, Neil, that have shown that the zero point 0.01 dose has been effective in slowing progression in East Asia, in Singapore, and Hong Kong, and in Japan, less so in a study presented from Western Australia, and different from a study presented just a month or so ago in our country, in the US, which found that 0.01% did have a significant slowing, a statistically significant slowing in the rate of myopic progression.
So what might account for these differences then when we don't have a consistent finding, at least when we're treating ophthalmologists? I know we hesitate to go in with a new treatment. Should we have some hesitation here when the PETA group seems to show no effect of these drops and other trials had suggested an effect? What does this do to clinical practice at this time for pediatric ophthalmologists?
Neil, this is a dilemma. In my mind, we have to look at the trials as best we can to understand what differences there were. Now, in the studies done in the US, the populations look the same. The follow-up rates did differ slightly in terms of our study having, fortunately, 95% return. The other study from the US did have a little bit less follow-up. They also treated over 3 years. The difference in the statistical outcomes is there, but there is also a small benefit in the other US trial. Lastly, the clinical effect in the other US study was only 0.24 diopters over 3 years. And that difference, in my mind, is not the kind of robust treatment effect we were hoping for in these studies. So we do have 2 studies, 2 different outcomes in them, and the clinical effects of the drug, at least in the US, have not been as robust as the treatment effects seen in East Asia.
And is there any reason to believe, is there a biologic rationale that atropine should work one way in children of Asian descent and another way in children of European descent, for example?
I don't think we know of what that reason or rationale might be. We do know that children in Asia do progress at a more rapid rate than they do in the US. So it's possible if you have a similar impact, it might have a bigger dioptric impact on the progression of myopia. But I think it's safe to say we don't know. We also don't know how the formulations might vary in terms of stability, tolerability between what was used in our country as well as compared with what was used in Asia.
So when all is said and done, at least in the US, what might the pediatric ophthalmologist say to the patient and their parent or caregiver who asks whether they should be considering atropine to slow down myopia when their child already has a little myopia, when they just ask, what's your opinion? What do you think we should do?
So I think there are 2 things these studies we should at least use to interpret. The first is we only tested 0.01%, and 0.01% was the only positive outcome in the CHAMP study. We don't know how stronger concentrations like 0.05 will do and need to be studied in the future. Recall that 0.05 is now the go-to agent in many East Asian countries after the LAMP study showed that it seems superior to 0.01. So I think that the things to tell parents today are myopia is not just eyeglasses. You are trying to, as an individual and as a population, lessen the impact of myopic diseases of retinal detachment and myopic macular degeneration 50 years from now. And we're looking for the best treatments. And this field is clearly an evolution in that search. And ophthalmologists should begin to introduce that conversation. I think it's fair to say we don't know the best treatment for your child, but we are looking, and there may be treatments in the future that are more powerful than what we have found to date.
Any plans for PDIC to look at 0.05% atropine?
We'd love to look at 0.05% atropine. I think it needs to be done in the U.S. We just have to look and see whether our resources are available from our NEI funding to make that possible. I'm sure every clinician who's participating in our research group is become very interested in the myopic question. So what would have been a backwater of research, at least in pharmacotherapy, is now front and center of everybody's what we need to do next study list.
Dr. Repka, we are so appreciative of the work of your entire group and your leadership, and for your sharing information from this randomized clinical trial again. Thank you so much.
You're welcome, Neil. I think we can do nothing but applaud the researchers and the families who have worked on these projects. And they did struggle through the COVID period, and we had investigators doing curbside drop-offs of medication, taking it to homes when universities shut down. So it was an effort, and everybody contributed to the excellent outcomes that we've done in terms of the research.
Well, thank you again. I'm Neil Bressler, and I've been speaking with Dr. Michael Repka, study chair for this randomized clinical trial on low-dose 0.01% atropine eye drops versus placebo in an attempt to slow myopia in children 5 to 12 years old, and no effect that was clinically relevant or statistically significant was shown in this randomized clinical trial. You can find a link to the paper in this episode's show notes. Thank you for listening to this JAMA Ophthalmology podcast. To follow this and other JAMA Network podcasts, please visit us online at jamanetworkaudio.com or wherever you get your podcasts. This episode was produced by Shelley Steffens at the JAMA Network. Thanks for listening.